Okay. Yeah.
Thank you.
So today we'll talk about intracerebral hemorrhage. As you know, intracerebral hemorrhage can be intracranial or in the brain, or it can be extracranial, like in subdurals or epidurals. We wouldn't be talking about those. We would not also be talking about subarachnoid hemorrhage. It's pure intracerebral hemorrhage. So, oh, this is not moving. Okay. Okay. So let me make sure. Okay. So the chapters today is we'll discuss about the OMG case, which is oh my God. And then we will talk about the ABC D5 and whatever the excitements which is happening in the field, because intracerebral hemorrhage is like, if you have it, there's not much we can do type of situation to something can be done in these patients also, and whatever the hope we have. So before we delve into that main topic, you know that stroke is happening every 40 seconds. As per the American Heart Association, around 800,000 people suffer from strokes every year. It has a huge impact, and mostly it's a social disease, as I keep on telling people, because you're completely a different person after you have a stroke. There are two types, and one is the ischemic, which is the most common type, is 85 to 87% people have it. The other one is the hemorrhagic, which we will talk about, which is mostly the intracerebral hemorrhage we will be focusing on. So this is a case where you say OMG or oh my God, you know. So this is an 80-year-old person who comes in with atrial fibrillation on anticoagulation, presents to the ER with some right-sided weakness. Exam shows that she is alert, awake, female, enough to continue the conversation, and examination shows a mild right facial droop, and a mild right hemiparesis. INR is 3.2. While waiting for a bed, which happens many times in the ER, right? You're waiting for the bed, either the ICU in this case, because it's an intracerebral hemorrhage. Now the patient becomes obtunded, unarousable, and starts having decerebrate posture. Whenever these things happen, you say, oh my God, you know. So what exactly happened? So this is what happened. This is what the stroke was. As you can see, this is the brain and this is the skull. Anything inside the skull which is white is either blood until proven otherwise. Other things which can be white are calcium and lipids, although it shouldn't be as asymmetric. And then look at what happened. I'm sorry, the whole picture did not get captured. This whole thing expanded and she herniated in front of us. So it's very important that ICH or intracerebral hemorrhage be taken as, as important as ischemic stroke. Although there is not much you can do, but you have to stabilize these people as fast as possible. So the ICH by the numbers, there's a 10 to 15%, as I showed in the graph, is related to the bleed. About 2 million strokes every year worldwide. But this is what I wanted to focus on. Prognosis is poor, and the mortality is in 30% at 7 days. In 7 days, out of 100 people, 30 will die, 60% within a year, and 82% in 10 years. So overall, the mortality of the patient increases significantly if they have intracerebral hemorrhage than non-intracerebral hemorrhage. The risk factors, definitely number one risk factor is high blood pressure. Number two risk factor is high blood pressure. Number three risk factor is high blood pressure. I can go on for the first 10 as high blood pressure. That's the most important cause of intracerebral hemorrhage. Other things like diabetes and alcohol, and if people are now more and more people are on aspirin and Coumadin and NOACs, which are the Eliquis, and all of which puts up at risk, because as we get older, the risk of bleeding increases, irrespective of whether you're on antiplatelets or anticoagulants. But when you add these things, the risk increases even further. Vascular abnormalities, definitely drug use, mostly in young people, trauma, as well as vasculitis. So the mechanism of ICH is mostly high blood pressure, but there are times where there's vascular malformation and intracranial tumors. In some elderly patients, we can have cerebral amyloid angiopathy. And then when people snort good things in their, through their nose, with cocaine and stuff, that doesn't help with the blood pressure because there's a sudden rise of blood pressure, and that's where the blood vessels leak. Hypertension is the most important factor, and most of the time, because of this chronic hypertension, all the blood vessels become more and more narrow, and they become under huge stress. And then there is persistent lipid deposition, as well as platelets and fibrin, and eventually one of them break, and that causes the bleeding. And once you start bleeding, it's, there's no way to control it. And sometimes you also have small aneurysms, not the large aneurysms that we talk about in the arteries. These are aneurysms of smallest nature. They eventually rupture of the microaneurysm and causing the intracerebral hemorrhage. Vascular malformations are known to cause ICH, mostly in younger female patients when they have a family history of that. And there are certain signs, which is like this is a popcorn sign, which is you have a stippled thing around the margin of black shadow, which is the bleeding. And this is a AV malformation. These are the different areas of the brain that can have bleed, and we'll go through individual of them. So one of the common things as we get older is, and we see this, is a lobar hemorrhage, which is the hemorrhage at the cortex, at the cortex of the brain. So these small arteries eventually rupture, and these are the cortical branches. They have the best outcome because this area of the brain is, but the rest of the brain is all intact. But eventually, some people, if it's really big enough, then they can go into coma. This is what the commonest garden variety of ICH that we see, which is the basal ganglia one. You can see that from the main artery, the lenticular striate branches have gone out, but if this is under chronic pressure, eventually one of them will rupture, and that will cause the bleeding. This is definitely much more problematic and carries up because all the fibers from the top are coming through this area. So a small amount of bleed can cause a significant amount of deficit, and it carries a poor prognosis. Then there are the ones which is the thalamo-geniculate branches of the PCA, which is the thalamic bleed. That's another common cause, and it's 10 to 15% of the cases we see that. One of the things that when we see a patient like this is very close to the ventricle, as you can see. And so these people develop hydrocephalus, and they respond to ventriculostomy. So that's the reason these people need to be watched very closely in the ICU. Then the other common cause is cerebellum, and that has a surgical implication because there's not too much space in that back of the brain, and people need to get, if it's more than 3 centimeters, they need to be evacuated of that area, or even sometimes we do a lobectomy of the cerebellum. This is again one of the penetrating branches of the pica or the ica, and people have with cerebellar symptoms, as most of the people have abrupt onset of headaches, nausea, vomiting, vertigo, inability to walk in the absence of any weakness. But they can have ipsilateral ataxia, where they have finger to nose problem, or even with horizontal gaze, so they can have double vision. And if you don't release that pressure very fast, eventually patients go into coma and herniate and die. Cerebellar strokes are always, whenever you hear the cerebellar stroke, you have to raise your antenna that person most likely would not need to be in a regular floor. That person should be, at least for the first 24, 48 hours, until it's a very, very small cerebellar stroke, or until the person is like 82 years old with a cerebral stroke, because you have space, so they can accommodate that for some time. But for a young person, you always have to take those patients to the ICU and watch them very closely. So these are again by the location. So this is a ganglionic bleed. This is a thalamic bleed. This is a ganglionic bleed which is spilled into the ventricle. This is a pontine bleed. This is a cerebellar bleed. This is a temporal bleed. So what are the features between a ischemic stroke and a hemorrhagic stroke? Most of the time, they start with headaches. And brain does not tolerate blood well. So anytime there's any part of blood in the brain, it gets irritated. So headaches, vomiting, and loss of consciousness is something which is very common. But it definitely depends on the size, how the loss of consciousness. If it starts bleeding and you there's no way the bleeding stops, then people go into coma and herniate and die. But it is mostly progressive. So when it starts, then in the next few minutes to a few hours, it will progress because the oozing continues, even if the bleeding has stopped. Sometimes with lower hemorrhage, people can come with intracerebral hemorrhage, and that's one of the things that we have to. In those people, we start them on anti-seizure medications. And depending on the location of the bleed is the neurological deficits. As in most things in medicine, we want the ABCs, to be the airway, breathing, as well as the circulation to be in control. Many times people have so low loss of depressed consciousness that we have to intubate them to protect the airway. And the main thing would be in this, and I'll show you that in the next 3 hours, everything in neurology is the golden hour is the first hour. Whatever you can do in that first hour to the first 3 hours will be the outcome of the patient. So it's so dependent. And that's the reason we say the golden hour is because within the first hour, whatever happens. It's not like kidney problems or cirrhosis or even sepsis, because those are the things which will build up with time, and then it will eventually, the system will break. Regarding the monitoring, we generally admit these patients to the ICU, and it is true that size doesn't matter in most of the things what you do in life, but it matters in ICH. The prognosis completely depends on how big the bleed is. And as the common question is, so is it expanding? All ICHs expand. And when do they expand? In this graph, you can see the first 3 hours. Where is the patient in the first 3 hours? In the ER, right? Because many times if we don't have the beds, the patient is sitting in the ER. So that's the reason it is important that's the reason I keep on saying the first 3 hours, you have to be proactive. You have to put that nicardipine on. If you have to control that blood pressure, that is important, because that depends on what will happen to the patient down the line. You get many times people question, and even some of the neurologists question, why do we have to have a CT angiogram in a person with a intracerebral bleed, which looks like a hypertensive bleed? And this is the reason. When you do the CT angiogram and you see these dots, which you can see that's shown by the arrow, that means these are the leaking blood vessels. This tells you that this patient will worsen in the next 6 hours if you are not on top of the blood pressure and reversal of the agent. And that is the reason sometimes CT angiograms are important to be a guiding tool to tell you how bad this patient will do eventually. There are other ways to look at it too. If someone has an ApoE, as you know, ApoE is very now well known in the whole media because of Alzheimer's disease. Because if someone is an ApoE homozygous, then that person's risk of Alzheimer's disease is significantly high. So if there is an ApoE person, they tend to have worsening of their ICH with the blood pressure. Similarly, there are some MRI studies which shows that if you see areas of ischemic stroke while you see the bleeding, that's a bad prognosis. So if someone comes in with the bleeding and now you do an MRI and you see dots of ischemic stroke, that tells you that person will have a bad outcome. And regarding the ICH score, that is absolutely important. And I think I generally dictate in my note, but it should be part of our DNV. That's what they look into, is because it directly relates to the mortality. The higher your ICH score is, the mortality. If your ICH score is 5 or 6, your mortality is 100%. So although we do not give up, we do not have a nihilistic attitude towards ICH whenever the score is high, but you can tell that to the patient and the family that because of the high ICH score, this person would not do well, whatever we do. That doesn't mean that we are stopping doing anything. And it comprises of few things. One is ICH volume. So generally, this is the volume that the radiologists read in their report, that how many cc's. If it's greater than 30 cc's, you get a score of 1. If it's less than 30 cc's, you get a score of 0. If there is intraventricular hemorrhage that I showed you in one of the things, then you get a score of 1. If there's no intraventricular hemorrhage, you get a score of 0. If it is below the tentorium, that means in the cerebellum, in the brainstem, then it's a score of 1. If it's not, you get a score of 0. Age is never a good factor for any neurological disease. So 80 is the cutoff. So if someone has an intracerebral hemorrhage after 80, they get a score of 1. If it's less, then you get a score of 0. And then depends on the Glasgow Coma scale. If the person is awake and talking, what she was in our patient at the beginning when her score was 13 to 15, and then it became to 3 to 4, well, if the score is, depending on how worse your neurological exam is the score is higher. So if it's 3 to 4, it's 2. So if, for example, in our patient who was 80 plus, has a huge, you could see that bleeding. So 80 plus is 1. It was in the supratentorial region, so it's definitely, that's a 0. It's greater than 30 cc's, it was 1. Intraventricular hemorrhage was, ventricular extension was there, so there's 1. And Glasgow Coma scale was 2. So it's 2 plus 1, 3, and 4 and 5. So this person, the person which we talked about, already you know from the get-go that that person's mortality is significantly high. So treatment of hemorrhagic stroke, first of all, the blood pressure, and I will talk about some studies that has been done. Interestingly, none of the studies have shown that it is really, really the way to go, or it was really positive, but it did not show that there was any harm to it. And that's where most of the field has gone, that you cut it to 140 and below. But there's a lot of controversy about that number, because if a person comes in with a blood pressure of 250 and you drop it to 140, that's a lot of drop. And that can cause a lot of other end organ damage and all that stuff. Definitely fluid management is something which we always do. We all never want to use a hypotonic saline. And regarding aspirin, we wouldn't give aspirin to someone. Our surgical evacuation depends on the location. And then ICP monitoring, we do not do at Beverly. And sometimes we use calcium channel blockers, but that's only for subarachnoid hemorrhage. So blood pressure control is important. And blood pressure causes a lot of ways to, first of all, there's a concern for increasing the hematoma enlargement. Increased blood pressure causes increased edema. Increased blood pressure is associated with poor outcome as well as end organ damage. On the other hand, you don't want to drop the blood pressure too much, because then there can be also associated damage from the ischemia. So 140 is something which we always target. But when it's 190, that's not a good thing. So something around 140 and just below, like 130 to 140, sometimes I will even push it to 130 to 150. In that way, they don't get, I don't get calls from the nurses. Otherwise, you get too many calls that, hey, what to do? It's too low or too high. So mostly, as they say, between 150 to 220, we would like to keep the blood pressure 140 and below. But as I told you, that really intensive blood pressure lowering in ICH did not result in significant reduction in death or severe disability. So although we do it, we know there's no harm, but it does, just on a direct trial, that did not show that it does anything as far as the disability is concerned. And this is the Interact 2 trial. You can see that they lowered the blood pressure and kept it there in the range that they were targeting, versus one that has blood pressure all over the place. So that's a standard treatment. This is an intensive art treatment. And when they did it, they came to the conclusion that not associated with excessive hazard, appears to reduce hematoma expansion, and it's clinically feasible, but no effects on clinical outcomes, and other studies are needed. And there's a question of this ischemic penumbra, that if you drop the blood pressure, what happens to the surrounding tissue around that area of the hematoma? And studies have shown that there is a little hypoperfusion, but clinically it does not affect in the outcome, as we proved in the previous slides. Now, this is something which definitely is of importance, because more blood means worse outcome. So whatever we can do to reduce the bleeding always helps. And reversing the INR is our first priority along with your blood pressure, because that's the longer this will take to stop the bleeding, the worse will be the outcome. So no more, we don't use the FFPs anymore. We go for straight for the Kcentra, which is the prothrombin complex, and we give vitamin K along with it. When they did a head-to-head study, they found that it takes almost 11 hours to reverse the INR when you do FFPs. And that's a lot of fluid you're giving to the patient. Whereas Kcentra, within a half an hour, you're reversing the INR back to 1.4. That's what most of the neurosurgeons feel comfortable doing surgery. It also shows that effective homeostasis is obtained in both groups, PCC non-inferior to FFP. But if you have to reduce the INR faster, Kcentra or PCC is superior to FFP. What are the adverse effects? That's one of the things that we always want to consider, because if there is a tiny amount of someone fell with a Coumadin or on Xarelto and has a tiny subarachnoid hemorrhage, is it worth to reduce that or to stop that? Now, if it's Coumadin, you know that effect will be lasting for long, so you can observe them very closely. But if it is one of the newer agents, either Eliquis or Pradaxa or Xarelto, because if you hold those agents, then in about 12-24 hours, it reverses back to baseline regarding your coagulation. So in some cases, you have to use clinical judgment, and we don't always give Kcentra to everyone, because you increase the risk of thrombogenicity. You increase the risk of DVT. FFPs has a problem with the fluid overload, as we showed, and then some people can get MI because of the fluid overload. Advantage of PCC or Kcentra type medications is less volume, rapid reversal within 30 minutes, and rapid infusion rate. And this is the dose we don't have to remember because pharmacy does it for us. Regarding patients with, so this is the guideline statement. Let me move it out from the A because I can't see my own slides. That if patients with ICH whose INR is elevated because of a warfarin type medication, it should be withheld, replaced with vitamin K, and correction of the INR to receive whatever you want to do. But PCC have fewer complications and correct INR more rapidly than FFP, and that should be considered. But the factor 7A does not replace all the clotting factors, and that should not be considered until someone has a factor 7A deficiency. So this is your NOAC list where all the NOACs are they all possible with the 4-factor PCC, which is Kcentra is a 4-factor, and so that's the reason most of the time when people come with apixaban or Xarelto or dabigatran, we still use the Kcentra. There are specific antidotes of Kcentra as well as dabigatran, but we generally use the Kcentra first. And one other interesting thing is the dabigatran, you can also hemodialyze the person. That also removes the medication. So whoever wants to know this, you can get it from the slides. We talked about dialysis, remove 60% of the medication in dabigatran. Regarding the NOAC, the AHA statement shows that that for patients with ICH who are taking dabigatran, rivaroxaban, or apix-7, treatment with FIBA or other PCCs might be considered on an individual basis. Activated charcoal can be used in the first 2 hours. And although FIBA is an anti-inhibitor coagulant approved for hemophilia, but we generally use PCC in the ER. We do have Praxiban, believe it or not, at Beverly, and this is used only for people with dabigatran-induced bleeding. What about heparin? Generally, it's not an issue because If you find someone, you can always stop the heparin and it reverses in 2 hours. That's the reason we hold heparin before you go to, someone takes them to surgery. But if it is like someone pushed the heparin and they saw the bleeding and there was a situation like this at another hospital where the person came in with a chest pain, and by the time the person came in and then started having shortness of breath, so the person got intubated. The EKG showed a classical ST elevation. STEMI was called, and then someone said, "Hey, let's also do a CT scan," because he was kind of a little goofy. So they did a CT scan, and he has a massive subarachnoid hemorrhage. So they started the heparin there. So in those situations, they stopped the heparin, gave the protamine to reverse the heparin. But in most of the cases, if you hold the heparin, then it reverses in 2 hours. So that's the dose of the protamine sulfate. What about platelet transfusion for people who are on aspirin and has intracerebral hemorrhage? There is prior platelet use does not affect the hemorrhage growth or outcome after ICH. So they had a platelet study. Excuse me, sorry. They had a platelet study where they used platelets after ICH, and that did not actually improve outcome. Actually, there was harm. So that's the reason we don't give platelets when people come with have been on antiplatelets, aspirin, Plavix, or even Brilinta. Now, there are some studies where we have used antiplatelet medication, for example. There is a medication called tranexamic acid that we have sometimes used for any type of bleed, because that has been found. And there are some sometimes we have done a DDAVP to improve the platelet dysfunction. But there is nothing that with platelet transfusion reduces your risk of or it helps with the outcome of an intracerebral hemorrhage on a patient who's taking antiplatelets. So the AHA guidelines tells you that usefulness of platelet transfusion in ICH patients with a history of antiplatelet use is uncertain. Other than some people have thrombocytopenia, then you have to replace it, yes. If the platelet function is normal, then that it's not thrombocytopenic, then there's no role of platelet transfusion. Factor 7 and ICH. This is a phase 3 trial which was done in hemophilics. It definitely reduces the ICH growth. As you can see, the hematoma volume definitely reduces with the higher dose. However, there was no eventually clinical benefit noted, and there was some increased risk of MI and ischemic stroke. So as a result, there was no recommendation for either the low dose, which is the 20 mics per kilo, or the higher dose of the 80 mics per kilo. So factor 7 can limit the extent of the hematoma expansion in non-coagulopathic ICH patients, but there is an increase of thromboembolic risk, and hence no clear benefit in unselected patient. It is not recommended. So this is your short gist of what the anti-reversals are, or the reversal agents are. For warfarin, Kcentra as well as vitamin. For warfarin, we can use Kcentra and vitamin K. For NOACs, if less than 2 hours, we can use of ingestion. We can use activated charcoal. For NOACs, we can use the PCC or factor 8. Now we can use, we don't have it, but we can use, like here it says, apixaban, rivaroxaban, we can antidote, which is Andexa. For dabigatran, we can use hemodialysis or Praxiban. But these things need to be done sooner than waiting on it for a long time, because the earlier you do it, the earlier you have at least has a chance to stop the bleeding, and which eventually helps the patient to get less disability. What are the complications of ICH? One of the complications is increased ICP. We know that if there's blood and there's only skull, so there's no place for the blood to go, and the ICP increases, and we have some slides about that. Seizures, hydrocephalus, DVT, and PE are the complications. So this is what happens whenever there is something in the brain, because the brain is in a closed box, the skull. anytime there's a space occupying lesion, either it's a blood or a tumor or tissue like a stroke, immediately the brain starts to have to accommodate that. And what it does, it starts going downwards towards the spine and accommodates for some time, and then it cannot accommodate anymore. And that's when you see people are, so this is how it goes. So you can see that there is a significant amount of time when nothing happens, and then it still can take it up till here, and then it goes up really fast, and that's when people herniate. And this is the same thing which we say is spatial decompensation, and then you kind of exhaust your capacity because there's no more space in the spine for the fluid to go. So that's when the tissue, the ICP goes up significantly. Now, as a nurse, this is something which you can do on all patients with increased ICP, and that helps tremendously. One is the head position, which is keep the head in the midline. So what's the reason for that? When you keep the head in the midline, the jugular veins are all open, and so the drainage is better. So you don't put the head like this or on like this, or and keep the head in around 30 degrees because that's when the drainage is maximum. Make sure that the temperature, the person doesn't have a fever. And as you know, sometimes we use TTM machine for controlling a normothermia, not necessarily a hypothermia, but keeping the temperature normal. And then if there are seizures and fluid management, we'll talk about it. So head end has to be in the neutral position to reduce any compression of the jugular veins. Head needs to be at 30 degrees. And make sure that the patient is not uncomfortable, like they have pain or in the bladder distension or agitation, because all of these increase the ICP. There are some places that we even give a dose of medication like fentanyl before they do the suctioning, because every time you suction, the blood pressure goes up, and that's something which we should not be doing. And I know in our ICU, sometimes people are not on sedation, but that's something which we always want to be because that reduces the ICP. I don't have that case where everything you can see in the patient who has an EVD, that everything was high when they took the patient off the sedation. And so they started giving more mannitol, they started giving because everything, it looked like the ICP was really high. Till at the bedside, when you go in and you see that the person is grimacing a little bit, person is withdrawing a little bit, so and they have a tube going down their throat. That's not an easy feeling, So the moment we started the sedation, everything goes down. So that's the importance of sedation. And I know sometimes people don't like sedation because, whatever the reason it is. During hyperventilation, there is that role is very limited because generally we can't control hyperventilation for a long time. And so it's a short, like a short gap measure that someone the surgeon is on his way and the person is herniating, and given either the salt bomb or the mannitol at the full dose, and you need to tide this patient over to the OR. That's when you can do hyperventilation for a short duration. What are the ways to reduce the intracranial pressure? One is definitely the osmotic diuresis, and mannitol is the thing which we have used all over the country in all hospitals except for Beverly, because we don't have a thing called osmolarity. We need to check the osmolarity every 3-4 hours before we can give the next dose of mannitol, because if the osmolarity is 320 and above, then there is a high risk of causing kidney injury and all that stuff. So all over the country, even in small hospitals, we have osmolarity except for Beverly, because we have a send out for this. So by the time I will get this is next week, where I have to decide on the next medication in 6 hours. And this is not the first time you're hearing it. For the last 20 years, I've been trying to, and I've been told that it is always there, but I never see it come as serum osmolarity. So we generally give a bolus of 100 grams over 30 minutes, and then 50 grams QR with osmolarity monitoring. Now we have, because there is nothing, no way of giving mannitol, now I'm using hypertonic at Beverly, but without any protocols. But that's the protocol that we will most likely set up in the next ICU meeting. That's easy to do, and we keep a range between 145 to 155. And then we have the 23.4, which is generally done with not a peripheral line, but a central line. And this is the salt bomb. You give that within the first 30 minutes. And this is what most of the people in the Army, they carry when they get a blast. When someone is injured with a blast, this is the first thing that they go and give it directly, so that to reduce the edema faster than and before they airvac the person. What about steroids? I know some neurosurgeons still use it, but as you know, neurosurgeons sometimes don't follow what the science is. And that's where dexamethasone has no role. Actually, there's a tendency to harm patients when you are putting patients on steroids. What about hydrocephalus? You can see this person had this is the normal scan, and this is already the bleeding is in the interventricular space. So that patient is developing hydrocephalus. There are two types, and the one which is the communicating hydrocephalus, we put in a external ventricular drain so that the pressure is going outside. And then if it's an obstructive hydrocephalus from something else, then we have to evacuate that problem. So EVD as a treatment for hydrocephalus is reasonable, especially in patients with decreased level of consciousness. So generally, we follow these patients very closely. And for example, you have someone with a bleed who's talking to you today, and next day you see that the bleed hasn't increased, but the edema has increased. And the following day, you see a hydrocephalus coming in, and they are becoming more drowsy. In those patients, you can put an EVD to release the hydrocephalus so that to see what, and that's something which we do mostly in patients with depressed consciousness. What about decompressive hemicraniectomy? It's the last resort, because timing of the surgery is important, but we generally want to do it if it's a big stroke or a big bleed. We generally want to do it earlier because you want to decompress that pressure and not have the pressure on the other vital brainstem organs. And this is how they do it. They take the skull out, they put the dura into 4 flaps, and then they do a duroplasty and keep it like that with the skin on top, so that the pressure, all the edema is outside rather than inside. And once you do a decompressive hemicraniectomy, our role of medical management goes down, because you can slowly taper off most of the medications, because that's the best space you could have given to the brain. So the approach to the ICP management is with you can reduce the CSF volume with mannitol or external CSF drainage or ventricular peritoneal shunt or a lumbar drain. You can reduce the brain volume by mannitol and decompressive hemicraniectomy, or the blood volume through either hyperventilation, hypothermia, head elevation, propofol or barbiturates, as well as the mannitol that we generally use. So you all know about ABC, but we talk about D5 in people with intracerebral bleed. So ABC D5. And what does the D5 include? Drop the blood pressure. We talked about it, 140 and below. Decrease the size of the hematoma. And how do you do that? By reducing whatever the medications they're taking to put the antidotes to it, like, with the PCC and the K-Centra and the vitamin K. Dehydrate the brain. How do we do it? With the mannitol or with the hypertonic saline. Divert the CSF, which is with the EVD, with an external ventricular drain. And if none of these work, then you decompress the brain with a decompressive hemicraniectomy. Now, this is very important for a couple of reasons, because remember, these are the people who are not moving for a long time. And the concern is, the person has a bleeding in the brain, so when do we start it? Generally, the recommendation is that once you have stabilized that patient and repeat scanning shows no worsening of the bleed, that's the time when there is stability of a radiological stability. That's the time from then you can start. 48 hours after that, you can start the regular DVT prophylaxis, because many of these patients eventually develop a PE because we don't do anything, and then eventually they develop a PE. Whatever the fluid status, we want to preferably keep it euvolemic, but we definitely would like to avoid hypotonic, saline, or D5s because that worsens the edema. Fever is potentiates the ischemic injury as well as you can use cooling blankets, acetaminophen, whatever it is. Don't want fever. Seizures. Sometimes it happens if the bleeding is generally on the surface because that's a cortical irritability to the brain, and those are the people that we put them on prophylaxis. But if the person did not have a seizure at the presentation, the risk of seizure is low, and that's the reason it's not recommended to put people on anti-seizure medications until they had seizures and many times these people, as we showed, is a subcortical bleed. So those are very low risk for seizure, like for cerebellar bleeds. We don't need to put them on anti-seizure medication, and I'll sometimes stop them because otherwise they are stuck in it for life. What about surgeries for ICH? This is the hope that we have, that previously we did not, because the previous studies which were done, as you can see, that the volume of the ICH, this is people with a high volume of the ICH, so this is your y-axis, this is your x-axis. So in 30 days, the mortality is less in people who have less amount of blood, which makes sense. If you have less blood, the risk of deficits are low, and the risk of any prognosis is good. But if people who have high bleeding, their mortality is pretty high. So it all depends, and there was a trial which was stage 1, stage 2, which they did surgery on a lot of patients, about 1,000 patients that they did this, and they randomized to surgery versus medical management, and this is what happened. See, the role of early surgery versus conservative management, it was the same result. So that's the reason previously neurosurgeons, you call them with bleed, they say, oh, there's nothing to do medical management, right? But now, so there was a lot of, in a way, criticism of this study because not all surgeons were the same. They were not doing the same techniques. So, so that was a question and for the pro and the cons group. But eventually, what we learned from them is that cortical, which are towards the surface of the skull, if those bleeding get better after surgery, and they can do well. But definitely the comatose patients did worse than the people who were not comatose. But there was a lot of variability between surgeons, the techniques. So that's the reason they had, the guidelines are that if this is a cerebellar hemorrhage, then, and there's a deterioration, that person should go for surgery because you can take the cerebellum out and create the space, and that would save, or you can do a suboccipital craniectomy and do the space, and that can save the person. But if you don't do it, that person will herniate and die. So that's the reason cerebellar hemorrhage is always a neurosurgical emergency. And until it's like a tiny, few millimeters of blood. There are ways to do an intraventricular or ventricular drain if there is a cerebellar bleed. Sometimes we prefer that you do this, the surgeons do the cerebellar thing directly rather than putting in an EVD, because when you put in an EVD, there's an upward herniation of the cerebellum that can also cause harm. So policy of early hematoma evacuation is not clearly beneficial compared to hematoma evacuation when the patient deteriorates. So if someone is stable, you can hold it, but if they are getting worse, then there's nothing to lose. You can go in and do the surgery. Now, these are the different gadgets we have now. And so there were two trials. One is the MISTY trial and one is the CLEAR trial. So what they did in both of these trials, first we'll talk about the CLEAR trial. So you can see that they put in a catheter right in there in the middle of that bleed, and they start giving TPA or thrombolytics. And when they do that, they slowly keep on absorbing the blood and then they suck it out. They do it and then suck it out. They give the medication, stay there for some time, suck it out. So that's the way they have done it. And however, the CLEAR trial did not show that it improved the functional outcomes at an MRS score of 3. But that's where most of the people have questions, because MRS3 score of 3 is pretty, you have very little disability. But these are the people who have big hematomas and big bleeds. So for them, they may have considered MRS3 as not the correct, domain for it. Then we had the MISTY trial, which has the same concept, but the CLEAR trial was for intraventricular hemorrhage. The MISTY trial was for intracerebral hemorrhage, as you can see. And then there was an ICIS trial, and I'll talk in a little bit about that. So regarding that, this is how they do it. We do it at PIH sometimes, depending on the location. So they have a radio-guided catheter in there, and then every few hours, they squirt the TPA in it, and then they keep it there for a few minutes and suction it out. This is the way they do it 3 or 4 times a day. And if you look at the studies, this is how it starts. This was the size of the hematoma. Once the scan is stable, you start doing this procedure. As you can see, eventually it comes down to this, where the bleeding has resolved completely. Or there is no, or this is another way. You can see the pre-surgery, 20 hours, 42 hours, 52 hours. That's the way they kind of take the bleeding down. Now, why is that? Because we know that the longer the bleeding is in the brain, it's more toxic to the brain. So the earlier you can remove the bleeding, the better it is. So that's the reason, in spite of the fact that they have intracerebral bleed, we still put in TPA and break that clot and get the clot out from there. So for moderate to large ICH, MISTY did not improve the proportion of patients who achieved a good response in 365 days after ICH, but procedure was safely adopted by sample of surgeons. Now, this study was done right across our, on the west side with Paul Vespa and group. So what they did was they went and put so if someone has a bleeding, they go in and take the clot out with a minimal scope. So they have a endoscope, which is almost like they go through here. It's almost a size of a quarter. So they go through here, and once the patient is stable for 48 hours, no expansion of bleed, they go in and suction the catheter out, the clot out. So early CT-guided endoscopic surgery is safe and effective to remove intracranial hematomas with the potential to enhance neurological recovery. This study is still going on, and we don't know the results, but my gut feeling is this will be a positive trial, and this will be the way to go in the near future. So minimally invasive surgery is feasible, safe, and improves mortality. Effect on functional outcome remains to be uncertain. Lots of interest in methodologies and everything. Now, so the keyhole brain surgeries are becoming more and more popular, because if you go through a small area of the brain, the total amount of damage is much less, and if you can get the effect, or if you can get whatever the surgery was planning to do, well, then less bone removal, less tissue disruption, less brain retraction. So definitely it makes sense that, smaller the injury is, or doing the surgery will be better than opening up the skull and retracting the whole vein and everything. And if you look at the subgroup analysis of MISTY and STITCH, both of them, you can see that there are people who favored the procedure. If they had a high 9 to 12 GCS, or if it's a deep bleed and a lower bleed, volume, everyone shifted towards favoring surgery. But the problem was this study was geared to MRS score of 3 and less. Unfortunately, these are huge bleeds. These people won't be 3 or less, that they will be independent in a matter of 6 months or a year after surgery. They still may have surgery, but when you do and remove those blood, the advantages are that you are causing less toxic damage to the rest of the brain. You're giving them the more chance to heal faster. So you'll see in the next slides, see the length of stay between medical management and the surgical, 38 days. That's a lot, or if you look at the treatment arm, the cost, that's the cost you reduced in these patients. The mobility was also much less was more in people who got the treatment than who didn't get it. So eventually, what does this mean? The greater the reduction in clot size, the better the patient outcome. So volume reduction matters. And I would put in a shameless promotion. which is that, we never know when to restart. Someone with an AFib comes in with this problem, with a bleed. We don't know when to restart it. So we are actually doing a study, which is a nationwide study, which we are looking into the timing between of starting this and to see which one works, apixaban versus aspirin. So people who have intracerebral bleed from atrial fibrillation, they are being put either randomizing to apixaban or aspirin, and we'll see how it goes in a year or two. What's the risk of stroke on this? Because the risk of stroke is high because they're not putting back on apixaban, but also we don't know what the risk of bleeding in these people are. That is also high because they had a previous history of bleeding. So in these patients, we just take a choice and tell them after a month, start it, and we'll see what happens. But we don't have a randomized data, and that's the reason that we are doing the study at the other side of the town. And I think that is it. And I'll stop sharing or whatever. Any questions? No? Yes?
Dr. Ganguly, hi, it's Elena.
Hi.
I have a question for you. You talked about the cerebellum stroke and you said the patient should go to the ICU. You remember we have a case like last week? Mm-hmm. So any comments about it?
Well, as I told you that day, that patient should be in the ICU. But that patient, I mean, to be fair, that was not a bleed, but that was a stroke. But anytime you have anything in the cerebellum, you have to be careful because there's not too much space. And so these people, they worsen very fast. And that is the reason these people with cerebellar stroke, and that patient mainly with that big stroke, that patient should never have been to the Tower 3. That patient should have gone to ICU from the get-go.
Is it depend on the size or any cerebellum stroke?
Most of the time it is any cerebral stroke, and mostly if it's young. I mean, that I remember that patient was like 37 or 38 years 37. Old. Yeah, so that patient, you don't have any space there. If as we get older, the brain shrinks, so there is some more space. But if anything in the cerebellum, you have to be over careful. I cannot strain that. I've seen patients who die right in front of us because, you don't have the time. And all of them complain of headaches. All of them are a little drowsy. You never know what is happening, and you have to be on top of with your neuro exam almost every hour to make sure that at least for the first 24, 48 hours till things settle down a little bit. So to me, if it is until it's like a few millimeter stroke, anything more than a sonometer in size should be observed in ICU, either bleed or stroke.
So if I see the report from the ER and it says more than 1 centimeter, should I have to say like we don't accept the patient, the patient has to go to the ICU?
That's right. That's what you say. That as per Dr. Ganguly, anything above a sonometer in stroke should be observed in the ICU.
Okay, thank you.
Any other questions? No? I think we are having the stroke meeting next week. And I think if I remember correctly, I need to know, I think Nancy was working on it. So I need to know from her regarding what's the status of the serum osmolarity. So if not, we say adios and see you whenever I see you next month, I think.
Thank you, Dr. Ganguly. Thank you.
Bye.
Bye.
Thank you, doctor.
Bye.